Hi, Andrew. Thanks so much for joining us on the podcast. The bio attached to your name now is very long. I wouldn't remember it. I'd love if you could just introduce yourself to our listeners, and then I'd love to get into a very brief chat about both the paper that you wrote recently with Tamar and which you reflected in a presentation here at the BHF.
So I started life as an academic economist. I taught economics for several years at a couple of universities. I joined the Treasury in 1993, and I worked in the budget office of the National Treasury, public finance issues. So health finance and our health system, public health services, was part of what I had to keep an eye on. But really, I was working at a much broader level. And I suppose what that means is that when I look at the health system reforms, the health financing reforms that are under discussion, the NHI proposals in particular, I always have at the back of my mind a concern about how this fits into the wider public finances, how this fits into the responsibilities of government that relate not just to health and education services, social services, but also to housing, employment creation, investment, municipal services, all of which need to be addressed as part of a strategy for development, and all of which contribute in some ways to improve living standards and healthcare. It's not just the health system.
100%. And now you find yourself in a more academic role again.
Now I've done a bit of teaching at UCT in the last few years in public economics, and I do a bit of research. I do a bit of consulting, and I like the opportunity to look into things in a bit more detail, which is what Tamar and I have done on health policy.
Super. Well, again, thanks for joining us. I'm obviously in the healthcare sector. I've been a long time admirer of your work and also Mark's work on the health financing side. And this paper that came out was I've made it required reading now for everyone at Insight and recommend it to everybody. I think it was a beautiful reflection of given your tenure over that whole period during the transition and now up to where we are, of the health financing reform, or as a lack of reform, as the case may be in our case. And I guess I just wanted to probe you on one or two aspects of that under one sort of umbrella question of how did we get here? I mean, it feels I had the opportunity to chat with Alex recently at our actuarial healthcare CPD day, and it feels like there was such a lot of good work that went into the Taylor Committee and all of the healthcare. We were on such a strong trajectory. There were robust discussions. The industry didn't always agree with at the time with what was going on, but so we long for that level of engagement now. And how did we get here of coming up on 15, 20 years of going nowhere slowly? What are your thoughts on it? Because I mean, you must have been at Treasury during some of that time period.
Well, the health system is complex, and ours is particularly complex. We have this mix of public and private health services, but within the health sector, there are so many different areas of specialization, different kinds of need, the blend of services, laboratory services, and radiology and specialist opinions and practices that come into play. And so I think where we went wrong in some sense is we were en route to institutional development in both the public and the private systems. In the public sector, I think of the hospital strategy project you remember from 20 years ago or so, which was about improving management and systems, creating a bit more independence in how public hospitals operate. And that lost momentum. And in respect of the medical schemes and private healthcare, we did some very sensible things in strengthening the regulation of medical schemes in the 1990s. But there were further reforms. The Risk Equalization Fund is a good example of that. Broadening medical scheme membership through low-cost benefit options is a second, in which the reforms stalled. And I think it stalled because we'd lost sight of the complexity, the need for institutional deepening, project by project, to make progress on these things. We lost sight of that in favor of a kind of political big idea. And the big idea was a unitary health system, unitary financing system. And that was the key idea in the 2011 Green Paper. And here we are in 2025 with the National Health Insurance Act that essentially is that same idea from 2011 of a single unitary system, but the institution complexity of the sort of sector by sector, component by component, work that needs to be done in leveling the playing field between the public and private systems. That work hasn't been done yet. So we have a big idea, but we really don't have an implementation strategy.
I think that is what seems to be missing from where I'm sitting. I mean, we grew up reading and learning from the Taylor Committee work and all of that substantive, meaty research and analysis, sort of data-driven decision-making with clear policies, clear stepwise things that would have to be done in a particular order in order to sort of reach where you want it to go. And I think that's what a lot of the tension around NHI centers on, is that, as you say, a big idea, but without a clear plan to get there. That uncertainty causes a lot of anxiety. People are not sure where they're going to fit into things, how the system is going to change. And I think that's, I said to one of the policymakers recently, it feels like the path chosen now is the path of most resistance rather than the path of least resistance, talking about one big fund. And even from some other speakers today at the BHF conference, really the most difficult kind of model to construct, given the assets and the structure that we have. So yeah, a really big challenge. I guess a follow-up question to that on how do we get here is, given your experience in government and treasury in particular, what would you suggest we go? Here we have these court cases which you've mentioned. They're subtractive, they're negative. They can't take you forward. All they can do is stop sort of the NHI process, or attempt to stop the NHI process. So what do we do now for those of us that are not involved in those kind of processes and really want to foster constructive, creative, progressive debate and discussion? How do we, what is the way to...
As a country, we have great resources. We have great medical schools. We have a huge amount of skill and expertise and experience in both the public and the private sectors, and in our medical schemes industry and amongst private providers. And I think there's a lot more innovation. There's a lot more working on practical solutions going on than is given credit. And some of that we're hearing about at this conference. The way forward is to break things down to specific issues. So in 2018, the National Department of Health published requests for proposals for 5 areas of work, quite specific things. School health services was one of them. Maternity care is another. Oncology services, the large backlogs in public hospitals in providing care and appropriate services to cancer patients. And these were areas where it was recognized that a collaboration with the private sector, collaboration with the private providers, well-contracted partnerships would assist in making progress. And we got quite close, and then it got stuck. And I think
nervous about tenders.
People are nervous about tenders, our tender process, procurement process, the rules, the sort of, everybody watching over everybody else's shoulder. Those we've got to get past that.
It's not an environment of trust. We've always found that being a big obstacle.
I think that's exactly right. There's a problem of trust. There's a risk aversion. And I have to say,
I think that's right.
If I'm honest about it, I'm going to say the Treasury rules and our public finance sort of audit and accounting environment doesn't help.
There, you get into big trouble. Even during COVID, some of the behavior and nervousness around procuring vaccines, etc., the risk of being sanctioned for, what do they call it, wasteful and unusual expenditure.
Yes.
When you, in an emergency environment, have to sort of operate a little bit close to the line just to get things done. People are extremely nervous.
Yes,
because it can be career-ending kind of accusations.
Yeah.
You spoke about, we need to be able to experiment and be comfortable with failure, but the way we've set up our institutions from a public financing point of view are difficult to do that.
Oh, well, exactly. And you need to be willing, when you're innovating, when you're undergoing reform, you need to be willing to make mistakes and learn from those mistakes and move on. You've certainly got to attack fraud and corruption if that's what emerges. But that's not always what's going wrong when the Auditor General is pointing to irregularities or mistakes. Often it is just about that sort of messy process of getting to solutions and implementing them. And we need to be willing to do that more. And it's not easy. I emphasize, and Tamara and I spend a bit of time in this paper on this, just showing how the public system works differently. It has different rules. Provincial hospitals provide services directly. The private health system operates quite differently. Insurers reimburse service providers. There's a whole institutional framework, set of ways of doing things there that has its own rules and systems. So to make progress in bridging the gap between those systems, you can't do it all at once. You have to do it by saying, right, we've got a problem in respect of emergency care at hospitals. How can we work together to improve there? How do we do better in distributing vaccines? How do we do better in distributing medicines? And distributing medicines is a good example of an area where in the last decade there's actually
Yes,
been quite
there's
a lot
been
of
some progress. Yes, absolutely. Yeah, the paradigm is very different. I've had the privilege of working with some colleagues at Western Cape Department of Health, helping them think about how to reorganize their cost data to even start thinking about DOGs, which is the mantra for hospital reimbursement. And I mean, it's the operating model is so different between public and private sectors. I've learned so as much as I'm trying to convey the DOG thinking into that environment, I've learned an enormous amount about just how differently public sector hospitals are structured. So that's been a great privilege. But the sectors are completely different in the way
Yes.
that even reflected in the data.
And when you work on partnerships, they might take a long time to contract. Well-structured public-private partnerships, thousands of pages of contract.
For sure.
There's a nice little example that we use in the paper of the Pelonome and Universitas hospitals in the Free
Yes,
State who put in place a co-location project. So basically, there's two public hospitals, academic hospitals. They created space within those hospital facilities for private providers to set up practices. And the idea was to share space and sort of economize on rehabilitation of the use of equipment and things like that. And one of the unexpected positive outcomes of that project was that the provincial health department found that with the private specialists operating on the third floor of the university's hospital or whatever, found that they were able to manage the rules that govern private work, what we call the RWOPS system, work outside of the public service, where everybody says, that system gets abused, people cheat, they don't spend the time that they should in the public hospital, etc. Well, put the co-location, put the people in the same place,
that makes sense,
and you can monitor what's going on, and you get and you can solve a kind of information and incentive problem of that RWOP system. And I think that's a good example of how you can when you get things right, when you learn as you go along, there are often secondary benefits from the reforms.
Right. But you have to have one of the mantras we have at Insight is to do better, which is a call to just always think about different ways to do things, new ways to do things, and not just do things in the way that has been done in the past. But it takes you have to have that kind of way of thinking. Otherwise you get stuck in a rut. I wonder if I could ask you then next the role that Treasury plays now in these macro reforms. I think people have the impression that Treasury is sort of the check signer and sort of the go no go decision maker in certain of these big reforms that may cost some indeterminate amount of money. We don't know. I mean, but what role does Treasury play in a reform like in a sector like healthcare or NHI or public sector healthcare reform? Is it only the budget process, or how does Treasury get involved and engage the other actors?
Often what Treasury has to do is say no, and it does plays that gatekeeping role, and especially in the circumstances we're in now, slow economic growth, fiscal stress, rising debt levels, the Treasury is often just having to put a line under this and under spending limits. But as you know, Mark Fletcher, who has led the Treasury's work on health services and health reform and the health budgeting and sorting out the various grants that go to provinces for healthcare, is himself a doctor and a health economics specialist, and so he brings both a health perspective and a health policy perspective and a public finance perspective to the work. And so in some ways South Africa really is fortunate to have somebody within the Treasury who actually understands and cares about the health sector. And I think it's a pity that we've not made more use of that, if you like, sympathetic engagement with the health services, although it does often mean saying, well, we can't do it quite like that, we can't afford this. And of course this is an industry in which it's not just about public services, it's also about private healthcare and how that's regulated and the complementarities between them. We need more of the kind of intelligent engagement around the table, sorting out problems that involves Treasury, the Department of Health, but also the provincial departments, who are actually the frontline service providers, and private sector and health insurers who can contribute to finding the solutions that we need.
Is there the capacity, do you think? I mean, it feels like that's one area where we need to invest as we need more supply of doctors and nurses, etc. It does feel like we need to invest a lot more capacity to be able to engage, as you say, meaningfully and there's a lot. We have very strong academic institutions, lots of health economists and professors who understand health economics well. But at a public service level, on the Treasury side, on the Department of Health side, it does feel like they spread quite thin, if I can say. There are a lot of problems they're trying to solve altogether.
There are capacity problems, and this is a complex sector in which you need good research, good evidence, good data, good analysis in lots of different issues. And let's also face up to the reality of, in a slow-growing economy, in a sector in which personnel costs are a large part of the overall health spending envelope, and in which you're needing to expand services, you really have to worry about salaries and remuneration structures, and we've not done well there. We substantially improved remuneration in public health services with the occupational special dispensations that was introduced for professionally trained people 15 years ago. And it worked. It worked in the sense that it enabled the public sector to recruit, to bring in doctors, to bring in specialists, where often they just were unable to fill posts before. But remuneration and the salary structures are now a constraint in this period of slow economic growth.
It's a higher benchmark now.
And that's one kind of, really grasping the nettle. You've got to be very careful about getting those things right. Once you've got remuneration wrong, it's very hard to fix. And then the second thing I would say is we talked about this a bit earlier, the procurement system. We've got to recognize that we've got serious management problems in several provinces. They need to be addressed. And where procurement reforms are needed, that needs to be implemented too.
Yeah, the low growth rate is something I'm speaking about in a session tomorrow, actually, sort of trying to contrast create an alternative history to sort of try to get people to reimagine what the future might look like. We still get excited when the World Bank or somebody bumps our growth rate from 1.5 to 1.8, and we think that's fantastic, but that's still well behind the curve.
Yes.
I mean, we've wasted 15 years of economic growth, which, when you added up my very rough actuarial calculations, we should be 50% larger by now if we had just followed world growth average world GDP growth per capita.
Yes.
And that translates to more jobs, more tax, more to spend on, and we just have, it's a whole other podcast, I suppose, on the reasons for that and how to avoid it in the future. But that really does put a lot more pressure on the system.
Yes.
Let me, I don't want to take more of your time, Andrew, but I want to end off maybe with an idea. And this is something I want to pick your brain over coffee sometime outside of a podcast. But going back to, if we could get back some of the ideas, health reform, the mandatory membership, the risk equalization. The one idea that we exchanged an email and I wanted to just explore a little bit was, and it was part of the earlier reform ideas where there would be an SHI tax, or we could call it an NHI tax, just semantic, that SARS could collect and then centralize. That would be income-based, a percentage of some kind. And then that would flow either, through to the public sector as additional funding, or the NHI, which is just a different financing vehicle, if you're not a member of a medical scheme, or if you are a member of a medical scheme, which then was going to be mandatory. I think we've lost. I'm not sure we'll ever get that tabled back. But if you're not, if you are a member of a medical scheme, then that tax could flow through as a subsidy into that medical scheme, and you would just pay the delta in the contribution. Do you think that would be a sort of feasible? Could SARS play that role? Do you think it's a feasible policy suggestion to put into the environment?
Well, I do think SARS is the revenue collector. They're good at it. And so if we do reach a stage where we funding stream into healthcare, so that's not an implausible reform. And in the context of the controversy around raising VAT in the last a few attempts to get a budget through this year, I think we are going to reach a stage. It's difficult to raise taxes in general, but the social security tax is the one part of our tax structure that lags behind the rest of the world. Yes, I think that you could then think of that as a tax that funds a revenue flow either into a public insurance system or provincial health services, or into a medical scheme if you're a medical scheme member. And I think that, and I flag this idea in the table, I think you can also solve the problem of the risk equalization fund implementation to a considerable extent that way as well. So we have the risk equalization fund idea. It was modeled, it was tested. It could have shared funding between schemes in a way that takes into account really the higher medical costs in old age mainly. That's mainly what a risk equalization fund does is redistribute between age groups. And when that was looked at, it failed to pass the sort of political test 15 years ago, and it's been abandoned, partly because of the way in which it would benefit some schemes rather than others.
Yes. So there was an income cross-subsidy problem.
There's some complexities to it. But Ireland is an interesting country here because Ireland has effectively faced up to a similar kind of political problem with implementing risk equalization, but between its social health insurance funds, and it simply did it through the tax system. It said, okay, we will pay a higher subsidy to the medical scheme, to the insurer, for elderly people, and possibly for women, taking into account maternity care. And we could turn our medical scheme's contribution credit, which operates through the tax system, into a differential subsidy, effectively, that does the job of the risk equalization insurer. And doing that tied to sort of compulsory contribution, as you're describing, I think would be a very interesting reform.
I had the opportunity to lamentably present to some international health actuaries on their risk equalization fund systems: Ireland, Switzerland, Netherlands, Australia. And I put my hand up to say, well, I can tell you what we were going to do, but alas, we never got anywhere. And even there, I think we, are quite the opposite to what we've done now, which is, done too little technical work. I think maybe the risk was we did too much tech. That was such good work, but it took too long.
I agree with you, yes.
If we had just started with something simpler and learned and evolved, maybe we would have had that. But alas. On the tax, one last question on the tax, and then I'll let you go, Andrew. I've heard that Treasury is not fond of earmark taxes, though, because it creates these pools. It doesn't allow them to sort of smooth out surpluses and deficits. Do you think that would be an obstacle to overcome?
Well, treasuries everywhere in the world are reluctant to approve earmark taxes because there's a sort of loss of control for budgeting purposes in that. Our own history of an earmarked road tax, which goes back to the 1980s. In the 1980s, there was a share of the fuel levy that went into a roads fund, and the roads fund was sort of separate from the main budget. And what happened in the 80s, it was clawed back and cancelled because there was such a large accumulation of funds in that fund at a time when the rest of the budget was in trouble, and the Treasury Ministry of Finance said, well, no, you can't do that. So that's an example of why treasuries are generally not sympathetic to earmarked funding. But having said that, social security systems everywhere are earmarked.
Tend to be.
Our unemployment insurance fund is essentially earmarked, an earmarked tax. It varies internationally. I think you're always going to get some hesitation from a finance ministry. And I also think that one shouldn't think of earmarking as really solving the problem. You don't get more money just because you've got earmarking. And the healthcare is so large, it's always going to need more than the dedicated social security tax that maybe goes to it. It's always going to be reliant on a broader share of the overall tax base. So earmarking might help in some respects, but it might give a national fund some security that enables it to deal with a risk that you do have to worry about, which is that your funder can't pay. And so if you get into difficulties, if you get into difficulties such as we have with our compensation fund and the road accident fund at the moment, that you wait for 6 months or a year before you get paid, then you really lose the trust of service providers. And an earmarked fund that has sort of cash in the bank as a consequence of the earmarking perhaps helps.
Super. Well, that was fascinating, Andrew. I'm definitely going to be staying in touch to bounce around some ideas, and who knows, I'd love to do some research, try to bolster back up to Taylor Committee kind of research and technical work that can help bolster some of the reforms going on. But thank you so much for your time. Much appreciated.
Thank you, Barry. It's good to talk.